Uh, very good afternoon to all. Welcome back to our Department of Medicine sessions under our department for PG students specifically. This is our series of lectures under medical oncology. This is our second in series. Today's lecture will be by Dr. Ashish Singh. Sir has completed his MBBS and MD from CMC Vellore and has done his DM from Tata Memorial Hospital, Mumbai. Sir is currently working as Associate Professor in the Department of Medical Oncology, CMC Vellore. As you can see, sir was a very meritorious student, had received multiple certificates of honor and gold medals throughout his MBBS and MD time period. Actually, he also have multiple publications and various workshops that he have conducted. He is also involved in the conduct of multiple multi-central clinical trials in oncology at CMC Vellore as investigator and as also as co-investigators. So, for today, we'll be taking our lecture will be on approach to colon malignancy. If you remember, sir has taken recently a lecture on recent advances in lung malignancy and had promised this current lecture. So, I think it will be as interesting as before, and many have been loving your lecture, sir. And I think we deeply, greatly owe to you for giving your time to us. If any doubts or questions through the session, please feel free to ask. You can raise your hand or you can put down your questions in the chat box or unmute yourself and ask Professor directly. This lecture will soon be uploaded on our Department of Medicine YouTube website. So it will be available maybe the next week. So thank you, sir, again for agreeing to take this lecture for us. Over to you, sir. Thank you.
Thank you, Anju. It's always a pleasure to be talking to all of you, and thanks to Zoom that we are able to even reach out to people who are right now not in the institution. Anju, if there's any problem with the audio or video, just let me know, right? If just call on my mobile.
Sure, sir.
And also because I can't see the audience, so therefore what we'll suggest is if you have any questions, you can just type it in the chat box. Anju will take all of that, and then she will stop me, and then we will clear those questions before we move on to the next part of the talk. So shall I begin, Anju?
Yes, sir. Please start, sir.
Yes. So welcome everyone. Good afternoon. Today, I was asked to talk about approach to colorectal cancer, colon malignancies, and I have kept it basic, basically keeping in mind the medical postgraduates who are training, and unlike in our times now, they do come to medical oncology as well. So a lot of what I'm going to talk about will you will already know. However, it's always nice to just discuss once more and maybe to clarify any doubts. So as a brief outline, we have only 45-50 minutes. So I'll just be briefly touching upon the various aspects of this disease. And this is a pretty common problem worldwide. If you see, this is in amongst women, it is the second most common cancer, and amongst men, it's the third most common cancer. And the incidence and mortality varies geographically. This is also has to do with the kind of data you collect and you report. However, what's alarming is that globally, around 9 lakhs people are dying of this disease every year. So that's a huge number, and this problem is kind of increasing. So now in the brief 30-40 minutes, what we will just go through is we'll probably discuss what are the common risk factors. Are there some things which we can do about, some modifiable ones and some hereditary ones? There have been various advancements in this disease in the last 15 to 20 years. And as a medical oncologist, I'll probably touch upon my area. But having said that, you also need to understand that everything, the pathology has advanced, molecular pathology has come in, the endoscopic techniques have advanced, surgery has improved, our complication rates, our local recurrence rates have reduced, and also with now it's not only surgery for the primary, but with improving expertise, we are going after even metastatic disease, and some of those patients are actually living long term. So how is this all possible? How is this evolving? I'll just try to give you a glimpse of all these, And the most important thing would be how do we make it all happen for our patients. So the goal is the trick is multidisciplinary management, working as a team, right from everybody, starting from pathology to molecular pathology and the surgeons. Now, in terms of risk factors, we all know this. We have there are certain modifiable risk factors. Actually, this disease was pretty rare. If you see a couple of decades ago, and with increasing age, people are living longer. Smoking and obesity, there has been a rise in this disease. People are attributing a lot to the dietary factors like usage of processed meat, low intake of vegetables and fruits. However, it's also been shown that people who have increased intakes of nuts, high fiber intake, more physical activity, whole grains, they have lesser incidence in this disease. Now, in terms of hereditary factor, now hereditary onset in this disease is not very common. I would say if you see all colorectal cancer, most of them are sporadic. But however, about 15 to 20%, depending on what age group you're looking at, can actually have some hereditary things. And you're all aware of the FAP and the Lynch syndromes. Now, in other cohort studies, people have found that use of aspirin or NSAIDs, statin use, they all have been linked to reduced, decreased incidence. And this is for some reason, this is this is more common in males, and inflammatory bowel disease we are all aware of, and diabetes. Now, if you look at the pathogenesis of this cancer, we all know most of these cancers do arise in an adenoma. However, even in between the adenoma, there are actually two pathways. So there are actually globally, there are three pathways. One of the first one, the most common one, is the adenoma carcinoma pathway, also known as the CIN pathway, which is as prevalent as about 90%. And these tumors actually arise, one of the first abnormalities, actually, they arise from stem cells, which arises in the crypt, and then they form an adenoma. And over the next 15 to 20 years, it transforms into a carcinoma. And what happens over a period of time is multiple mutations, multiple epigenetic rearrangements, alterations, and which leads to also switching off of tumor suppressor genes like your TP53 and other mutations. The kind of mutations which occurs are different, in the genes are different. Does this have any importance? Yes, some of them have therapeutic implications. Some of them actually explain why patients actually, some of them, like with a normal colonoscopy a few years ago, suddenly comes with metastatic cancer. Therefore, so it's important to know that there are these three pathways in play. Now, in the last maybe 4 to 5 years, we have also learned that colorectal cancer, even though we say that in one breath, it's actually different. All three different diseases put together. Rectal cancers, we treat them differently. Even the colon cancer, sidedness matters. Now, so there is this division between right and the left colon. And actually, if you look at your embryology, the right and left colon, they arise. One arises from midgut, and the other one arises from hindgut. And even if at the molecular level, these tumors are different. And this was mainly noticed in terms of outcomes in patients with metastatic disease. And then now a lot of work has been going on why is there differences and what is responsible for the left-sided tumors doing better than the right-sided tumors. Now, what we know a little bit is that most of the tumors which are arising in the right, they are poorly differentiated. They seems to have some increased immune cell infiltration, and they have more KRAS mutations. Also, you should know that right side tumors, because the lumen is large, they don't present very early, so they usually present as a much advanced disease, and that also could be responsible for it. They're more incidence of mucinous tumors, and they probably arise more from the sessile serrated lesions. And all these factors put together are possibly responsible for their inferior outcome if you compare it with the left side disease. Now, so one is also recently, not recently, actually way back in 2014, based on gene expression profiling of these tumors, we are trying to classify them at the molecular level. Now, this is something which has been around for some time, but I should tell you that this is still investigational. We currently don't use it for any treatment decision making. but these things are clearly predictive and prognostic. So if you see here, you can divide colon cancers into 4 groups. The what we call the consensus molecular subtype CMS 1, 2, 3, 4, based on the gene expression and based on the immune signatures. You have the MSI immune types, the canonical, metabolic, mesenchymal. And if you look at the Kaplan-Meier curves on your right, you see that the blue ones, the CMS2, they seems to do the best, and then the green ones, which is the mesenchymal, they have the worst prognosis. And but the challenge is, how do we do it? Whether we should do it, it is still, as I said, it is still not standard practice, and it's still under investigation. Now let's move on to how do we manage these patients. Now, as I said initially, this is a team process, right? Your outcomes are the best if you have everybody sit down and discuss your patient. Each patient will present to you with different challenges. So ideally, an MDT will have your pathologist who makes the diagnosis and who guides you with the molecular subtypes. You have your surgeons who will help you with taking the tumor out. You have your medical and radiation oncologist who would make sure that the tumor doesn't come back again after a good surgery. And then you have a diagnostic radiologist who would guide you depending based on the kind of surgeries you can perform. And we all know the gold standard is colonoscopy. And for anybody who has unexplained anemia, bleeding for rectum, change in bowel habits, especially if it's older to 40, 45 years, you must have an endoscopy. You may want to do a stool occult blood just to confirm there is GI blood loss. But having said that, stool occult blood is not very sensitive. So anybody, and knowing that these cancers are common, especially in older people, colonoscopy, most people do hesitate, but I feel we miss a lot, especially knowing that early cancers can be asymptomatic altogether. By the time you develop symptoms, the cancer may already be in stage 3 or beyond. So therefore, it's important to kind of use colonoscopy. Screening in our community is not, there's no systematic screening advised, however, like in other countries. However, that is also it's coming up in a big way. Now, the advantages of a colonoscopy would be that you will be able to pick up early lesions. Like here, you see it's a nice polypoidal lesion, and on your right is a narrowband imaging, which can actually show you the abnormal vessels in a much clearer way than what your just light endoscopy will show you. And the narrowband imaging can sometimes also help you when the lesions are flat, like it's not a very prominent adenoma like this. Also, the importance of having a good preparation is important, because if your preparation is not good, you can miss smaller lesions. Now, so this is diagnosis. Now, next is how do you stage it? Now, most often is a good quality CT scan, which images your abdomen, pelvis, is good enough for colon. And we also would want to image the lungs. So usually we will order a CT scan of the thorax, abdomen, pelvis as one shot. Sometimes if you feel that the lesion is too early on colonoscopy and you may not need lung imaging, just an abdomen is good enough. However, when it comes to imaging tumors with in the rectum, it is important to know that rectum, if you can divide as low, mid, and high rectum, we all know that it's a small space, and then you have the sphincter below. And the reason why we divide them like this is because of their contact with the peritoneal cavity. If you see the figure there, higher rectum is predominantly in contact with peritoneal cavity, as opposed to the low rectum, which is nowhere near. It's deep down in the pelvis. And why is it important to do this imaging? Is because of this concept of mesorectum. Now, what is mesorectum? Now, you all know in your anatomy and pathology, you would have seen. If you see the yellow arrows there, that is the mesorectal fascia, and then you see the rectum in the center. The content between the mesorectal fascia and the rectum is predominantly consists of fat. That is where your lymph nodes rise. That is where your vessels are, and this was important because earlier days when the surgeons would operate, they would just remove the rectum and the tumor, and they would not care too much about clearing up this whole mesorectum. Then they realized that the local recurrences were much higher. And therefore, the importance of identifying the relationship of tumor to your mesorectal fascia was discovered. And then we all found that the best way to do this imaging is actually MRI, because MRI can clearly show you fat and the fascia and the surrounding structures. And also because pelvis is a small space, you've got your bladder, uterus, seminal vesicle, prostate. And also the surgeon plans its surgery. I mean, where his knife is going to go, and is the surgery likely to leave behind tumor or cells there? So this seems simple, but just shifting over to MRI, doing a good preoperative assessment has resulted in reduction of local failure rates in rectal cancer from as high as 15 to 20% to now in single digits, 3 to 4%. And this has really changed management. So this is just a figure I'm showing you an MRI, the importance of doing this MRI. The first picture, if you see, the tumor is black, and then the black arrow is a mesorectal fascia, and you see there's a big distance between the tumor and mesorectal fascia. But if you look at the image on your right hand side, you see the tumor and the mesorectal fascia. I mean, tumor seems to be infiltrating the mesorectal fascia anteriorly, and this is where you will call CRM involved or MRF infiltrated. Sometimes it's not only the tumor which infiltrates, sometimes it can even be a lymph node, which is just sitting right at the mesorectal fascia. And these are all the patients who should not go for upfront surgery. And if you go do an upfront surgery, their local recurrence rates are really high, and you need to do some kind of a downsizing, and that is usually chemoirradiation. You do radiotherapy along with some chemotherapy, and this is something which needs to improve. Now, surgery, this is just one slide to just tell you that for most, there are different kinds of surgery based on the location of your tumor. For tumors which are involving the lower rectum or the mid rectum, sometimes it's not possible to spare the sphincter. And that is when we do your abdominal perineal resection, and patient has a permanent stoma lifelong. But for most of other cancers, the stoma is not required, or sometimes when patient is very sick, has come to casualty, obstructed, he has low albumin, he has ascites. If you join them back, the chances of a leak is much higher. There, the surgeons would do what we call as Hartmann's procedure, and they'll bring out a stoma, which is temporary. Once you finish your therapy, maybe 6 months, 8 months down the line, the stoma can be reversed. Now, once your patient has had surgery, that is when they will be sent to you. And as physicians, you have to answer this question that does this patient require adjuvant therapy? Now, what do you mean by adjuvant therapy? Is basically when the tumor is removed, you're probably having micrometastatic disease in the body, and these cells would possibly will be the cause for relapse, and then you want to eliminate them. So an analogy will be like, as the surgeon is pulling the weed by its root, we as medical oncologists will be treating the yard to ensure that there's no subsequent seeds which ever grow. And but the challenge is that we really do not know in which patients we have these seeds which have to be treated, and which patients are rendered cured by surgery alone. And so at the moment, we just rely on the TNM staging, where the pathologist would help us after surgery. They will meticulously sample the entire specimen, look at all the lymph nodes that are involved, not involved, and they'll give you a T and N stage. And as you know from the figure in front of you, that based on your TNM staging, I mean, if you see that if you are lymph node negative disease, T3 and above, you're staged as stage 2. However, if you're T4 disease, T4A or T4B, even when stage 2, your prognosis is much poorer as compared to, for example, say T2N1 disease, right? So T size is extremely important. Over and above, I would say it's possibly even more important for T4 disease than your nodal burden. But as your nodal burden increases, your risk of failure increases, and therefore these patients are likely to benefit from adjuvant therapy. And this is just, again, emphasizing the same point that if you have a T4 tumor and you are N2 or N3, then your survival is as low as 20 to 30%. So therefore, these patients are at very high risk of relapse. Now, how do you decide on adjuvant therapy in patients who are early? When I say early, that means node negative. Not the T4s, but they are the T2, T3s. So they're mostly stage 2. And there, because the chances of cure is so high with surgery alone, your chemotherapy is probably not necessary. And it's been shown in meta-analysis and multiple trials before that if you give 5-fluorouracil in this group, mainly stage 2 with no high-risk features, your overall survival improves only by about 3%. So generally, to save these 3%, you have to treat the entire 100, and you lead to a lot of over treatment. So we would reserve our treatment mainly for people with other high risk features. Like if you have a poorly differentiated high grade tumor with lymphovascular invasion, or if you're presented with obstruction, those kind of patients where the surgery was emergency, or it was the lymph node dissection was not adequate, those kind of patients we would prefer. For most patients, actually, you can safely omit chemotherapy for stage 2. Also, of late, we have been classifying these tumors as some of them as having, we do study for what we call microsatellite instability or mismatch protein repair deficiency. So what we call MMR deficient tumors. It's also been shown in stage 2 that if you have MMR deficiency, your outcomes are very good. And by very good, I mean that's 93%, 90, above 90%. So in that situation, adjuvant chemotherapy also probably doesn't make any improvement. Actually, in these retrospective analysis, if you see, there's actually the people who got treated actually had a low inferior survival. So people are even thinking that can chemotherapy do harm if you have an MSI high stage 2 disease. Moving to stage 3. By stage 3, I mean when you have lymph node positive disease or you have a T4 Raj tumor. Here you make a big impact. When I say big impact, I'll say obviously the amount of impact you make will also depend on your baseline risk. That means your absolute gain will be much higher for a T4N2 when you compare it with a T2N1. However, on an average, you cure about 20 to 25% of patients by your systemic therapy. And about 20 to 25 patients will recur in spite of a systemic therapy. And the remaining 55 are actually cured with surgery alone. But then at the moment, we don't know how do we pick out these 55 patients. I'll show you that the field is moving forward, and we may be able to do that in future with using technology like cell-free DNA, where you can look at circulating tumor DNA in patients' blood after surgery. Now, in the stage 3 high-risk population, usually the most important drug we use is 5-FU, 5-fluorouracil, or there's an oral prodrug called capecitabine. Now, once you do that, your outcome, this is the Kaplan-Meier curve. You can see this is a 10-year follow-up, and most patients, like about, as I said, 25 to 30 will relapse, but the remaining patients are alive. If you add another drug called oxaliplatin, that is, when you add oxaliplatin to 5-FU, the regimen is called FOLFOX. When you give 2 drugs, you further improve these cure rates. At about 5 years, it's about 4.2%, and in the longer follow-up, it's about 8%. 8% absolute is a big gain. And so currently, if you have a stage 3 colon cancer or a rectal cancer, we do use FOLFOX, and we hope for an 8%, adding oxaliplatin improves your outcomes by 8%. We can further dissect on whether everybody needs oxaliplatin based on the burden of disease. So as I told you, if you got an N2 more than 4 lymph node positive, your risk of relapse is higher, and your absolute gain from adding oxaliplatin is about 13%. As opposed to if you have an early stage 3, that is N1, it's about 6%. Now, historically, when you see chemotherapy for most solid organs, take for example, pancreas, stomach, colon, we all say, okay, we must treat for 6 months. And this 6 months is actually not very evidence-based. If you actually look at history, long ago, that means about 40, 50 years ago, when they only had 5-FU, they used to treat for 2 years. Then somebody said, okay, let's treat for 1 year. Then somebody said, okay, let's treat for 6 months. And recently, there have been multiple trials and a large pooled analysis. It is called the IDEA meta-analysis, which looked at this question, whether we need to treat them for 6 months or 3 months. And what they found was, if you had a lower risk stage 3, that is T1 to 3N1, 3 months was non-inferior to 6 months. And if you had a higher risk stage 3, that is T4N2, the meta-analysis could not prove that it was non-inferior. However, if you look at the number needed to treat, or the number of relapses you're going to prevent every 100 patients you treat, it's about 38 versus 36. So about 2 extra relapses you will prevent if you treat them for 6 months. So this is a reassuring data, good for our patients. For most of our patients now, they feel happy when we tell them we should treat you for at least for 3 months. And for people who are expected to do poorly, we extend therapy to go for up to 6 months. Now, there's also another concept. As we were talking about rectal cancer treatment, now I told you if you have an abdominoperineal excision, you have a permanent lifelong stoma, and a lot of young people don't want that. We have patients as young as 25, as young as 30, and it's actually sometimes quite disturbing to know that okay, your cancer is quite early, but however you'll end up having a lifelong stoma. So for that, the field is moving towards organ preservation. By organ preservation, I mean you're going to preserve the sphincter. But then in order to achieve that, you have to ensure that the therapy you provide produces a complete response. And by complete response, I mean you assess it by on MRI and also on clinical examination. So how do we do that? We usually do that by giving them systemic therapy upfront. Like here in this situation, if you see this patient, the diagnosis, the yellow arrow is pointing at the rectal tumor. It's probably a T2, T3, and lymph node. Sorry, I can't see here. Maybe an early tumor, but low tumor. So if you do surgery here, you will have an end stoma. So you give them systemic therapy. You cause a regression of tumor. While doing that, you treat your micrometastatic disease, if any. Then following which you bring in your radiotherapy. Radiotherapy alone is not done. Radiotherapy is usually given concurrently with 5-FU or capecitabine. The recommendation would be to give capecitabine, but we prefer to continue full dose systemic 5-FU so that all what I was talking about, 3 months, 6 months, we don't want to break in that duration. And once you finish at the end of 4 to 5 months, there is about 25 to 30% of these patients you would be able to wait and watch, right? Or you can call it deferral of surgery. But it's important to choose these patients because some of them will have recurrence. And at the time of recurrence, you can go and salvage them by doing a surgery. And okay, so now I talked about adjuvant chemotherapy. Some of you may ask, can we do the chemotherapy before surgery? Like you do it all the time for esophagus, for stomach, for pancreas, and for rectum. Why not for colon? So this strategy is also being investigated. There is a randomized trial, large randomized trial, 1,000 patients. It's called Foxtrot trial, where it's neoadjuvant chemotherapy for colon cancer. And what the authors intended to do was they hypothesized that neoadjuvant chemotherapy will improve survival as opposed to giving chemo after surgery. And the trial was designed and finally it was conducted. I'm just taking you straight to the results. These are the recurrence rates, and if you see here recurrence rate, the pre-op chemotherapy had a lower recurrence rate, about 21% as opposed to 27%. However, this trial, if you look at the p-value, it's 0.08. Statistically, it was not a positive trial. And there's a lot of reasons for that. And one of the main reasons was that the control arm actually performed much better. I mean, just a 17% recurrence at 2 years is much lower than what you expect. That's possibly, I think, the patient selection in this trial was very cautious and they had taken extremely good patients. However, if you look at the details, the R0 resection, which we all know is very important for patients to be cured, was higher if you had a neoadjuvant chemotherapy. And also the possibility of you doing a complete resection improved to up to almost like more than 95%, as opposed to 11% of patients who went for surgery upfront did not have an R0 resection. So currently here, I think the whole field is evolving. I mean, what we were doing 10 years ago is very different from what we're doing right now. And as I was telling you that currently we don't know who will relapse, and that's $1 million question. And people are trying to find that out by studying what we call cell-free DNA, circulating tumor DNA. So this is a study where they took 250 patients. They all had their primary removed. And then once you remove the primary, you have the tumor with you. You take the tumor and you do a next-gen sequencing. You sequence the genetic material of the tumor, figure out 10 to 15 genes which are mutated, and you have a panel. So once you have a panel ready, you can actually run this PCR or run this NGS panel on any DNA which I provide you. And that DNA is what you take from the patient's blood, right? So you have a panel, it's like a probe, and then you use that probe to see if what was there in the tumor is coming up in the patient's blood. in the circulating DNA. So by doing that, you will divide this group. The authors in this study divided this group into two. One was patients who had circulating tumor DNA positive after resection, and patients who did not have DNA in their blood. And this DNA was detected by this panel which you diagnose. And as you can see clearly, even when you are stage 2 disease and you are clinically low risk, that this is a group where as an oncologist, I will say you don't need chemotherapy. You can be on observation. The hazard ratio of relapse is 28 if you were circulating tumor DNA positive. So this is huge. So, and also if you see the magnitude of the separation of the curves is also present in clinical high risk. So what I'm trying to tell you is that this genomic test is actually trumps any of the other available prognostic markers we have today. That is pathology or anatomical staging or completeness of surgery. And moving forward, I think this will really help us in identifying patients who will benefit from chemo and sparing chemotherapy for patients who do not need and who are cured by surgery alone. And in the same study, if you see here that if your ctDNA was negative, your negative predictive value was as high as 91%. On the other hand, if your ctDNA was positive, your positive predictive value was 100%. So this seems to be a very good test, which is just the challenge has been to standardize it and also to make it available to our patients. Now, the same thing what I just showed you in stage 2 holds true even for stage 3. Stage 3 is a situation where you would want to give chemotherapy to everybody, but a lot of the patients, even at the end of your chemotherapy, may be circulating tumor DNA positive, right? And that is what you see in your right-hand figure. And you can see there that if your adjuvant chemotherapy does not result in a negative circulating tumor DNA, at the end of your chemotherapy, they are at a high risk of relapse. So it's quite exciting. And this is just a table with univariate, multivariate analysis. I'm just showing you that, look at the hazard ratio, 28. So this performs way better than any other prognostic feature which we were using till now. That is T3, T4, MMR, no MMR, LVI, no LVI. So this is probably the way forward. Now, so I'll stop there with my early stage treatment. And Anju, if there are any questions regarding early stage, we can take now. And then in the next few minutes, we'll do the advanced stage.
So there's no questions in the chat box, I've said. Anyone, if any questions, please feel free to ask.
Please unmute yourself and ask.
Yeah. Anyone, any questions? Please take an unmute. Anyone can unmute. So do we have the circulating tumor DNA in our setting?
Yes, so we have the technology. Like we have if you see lung cancer, we do EGFR mutation on the circulating tumor DNA because we have the PCR probe for that, and we have a ddPCR machine, right? And we are moving towards NGS. I mean, we are currently establishing NGS on tumor tissue, and that should be available in the next maybe 6 months or so. And once we have that, it's running the same test on DNA extracted from the blood.
So as of now, so we have tailoring this for stage 2 and all, having this neoadjuvant.
So as of now, as I'm telling you, is this is still early research. It has not been validated to be used in. So, for example, I'll tell you, if you have a T4N1 patient who is circulating tumor DNA negative, would you not give him chemotherapy? The answer is no. So as of now, we still go by our traditional way of deciding who needs adjuvant chemotherapy. And but then this is something which can be used maybe for a stage 2, for an early stage 3. For those patients, yes. Also, it can have implications on following up these patients. So suppose you have a patient who finished chemotherapy and is ctDNA negative, that patient can be followed up maybe once in a year, as opposed to somebody who is persistently positive, you know he's going to relapse, and therefore you may want to follow him up more frequently, so that so that you can actually intensify his therapy then and there, or maybe at relapse you can pick up and do something like metastatectomy and other procedures.
Sure, sir. Thank you, sir. That's very promising, I think. Any other questions? I think, sir, we'll move on to
okay. So quickly, we have 20-30 minutes. So treatment of advanced disease, Now, advanced disease, if you see, what are the drugs we have? When I say advanced, let's talk about disease which is not resectable, which is maybe involving multi-organ or patients has clearly unresectable incurable disease. So historically, if you see, this is just 20, 22 years ago, the only drug we had was 5-FU. And as oncologists, we debated on that what is the best way to give 5-FU? Should we give it as a bolus? Should we give it as an infusion? Should we give it as bolus plus infusion? And that's why you have all these different regime, FOLFOX 6, FOLFOX 4, and so on. But as time has gone by, I don't have the time to show you each and every trial, but we have actually currently, if you see on the table, we have three main chemotherapy drugs. One is the 5-FU or capecitabine. Second one is oxaliplatin. Third one is irinotecan, right? And then in later lines, we have some of the newer molecules called TAS-102 or tipiracil trifluridine. In addition to these chemotherapy molecules, we also have monoclonal antibodies. We have two major classes of these drugs. One is the anti-VEGF blockers, which is bevacizumab or aflibercept or ramucirumab. And then you have your anti-EGFR monoclonal antibodies, cetuximab or panitumumab. Now they're all same. Like all the VEGFs are more or less same, and all the anti-EGFR antibodies are more or less same. You can use either of them. Now, so if you can see here, based on these 9 drugs, and recently with the discovery that MSI high tumors can also respond to immunotherapy, so we will add immunotherapy to this list. Now, as you see here, when you have a patient in front of you, you have all these 9 options. The permutation and combination, the possibilities are huge. Like you can just give 1 drug, you can give 2 drug, you can give 3 drug, you can give 3 drug plus a monoclonal antibody. So how do we decide that? So what influences our treatment choice is basically what your goal is. Okay, so number 1, most important is what is the goal? Goal is cure or goal is palliation. Now, when I say cure for metastatic disease, I mean that this is a disease where a lot of patients can be a long-term survivors if your surgeon is able to do an R0 resection. And where is it possible? Sometimes it's possible in the liver. Sometimes it is even possible in the peritoneal cavity. We all heard of cytoreductive surgery. We have heard of HIPEX. So that is one thing. And the second thing is, what is the patient's characteristics? Now, for example, if you have a 30-year-old young fit male with one liver lesion, you would want to do everything for this man. On the other hand, if you have a 75-year-old man with an ischemic heart disease and a lymph node in the para-aortic region, a T4 and 3 lesion, here you know that you're not going to be that aggressive. So your patient's characteristics, your age, comorbidities, performance status is important. The other important thing is the tumor characteristics. I told you, high volume disease, low volume disease, number of sites of metastatic disease, technically resectable, not resectable, that is important. Then also what's important is patient's preference. Like some patients would say, I mean, I don't want toxicity, right? I want to continue working. I don't want neuropathy. So based on that, you choose or avoid certain drugs. Also the molecular characteristics, right? Sometimes you may have a tumor which is BRAF mutated. You know that those patients do very poorly as compared to a tumor which is MSI high, okay, or a tumor which has RAS mutation. So based on these, you tailor your individual therapy according to your patient needs. And this slide just shows you that you have these 9 drugs, and then based on what you use, most of these patients undergo multiple lines of therapy. So if you see in the last 20 years, we have not discovered new drugs, but the survival seems to improve if you see historically. And the reason why that happens is we have learned how to sequence these options in the best way possible, give them a treatment-free interval and treat them when they relapse and do surgeries. So much and so that now with the metastatic disease, it is expected that your median survival should cross 3 years. Now, again, this is all data from the West. In India, you may say our patients don't have access to these therapies. They're expensive. They don't have access to good hospitals who can do good surgeries. That is our problems. But however, what we need to remember is that most of the Western trials now are reporting a median overall survival of about 3 years. So median is the mid number. Now, if you look at guidelines, what guidelines will tell you is you decide upfront based on the patient and the tumor factors that what is your goal. Your goal is disease control or your goal is cytoreduction, that is tumor shrinkage. If your goal is tumor shrinkage, we would be a bit more aggressive. And usually, if shrinkage happens, that patient will go for ablative procedures like surgery or RFA or HIPEC. If the goal is disease control, then quality of life and progression-free survival is important. Responses you don't care too much about. Okay, so based on what your goal is, you could use a doublet. When I say doublet, I mean 5-FU with either oxaliplatin or irinotecan. And when I say triplet, I mean all three together, right? And then these triplets, if you have a patient who is likely to respond to an addition of a monoclonal antibody, you could add to these, either to the doublet or to triplet. Sometimes if your goal is only disease control and it's not going to be cytoreduction, we do only like capecitabine with bevacizumab, extremely well tolerated oral drug, capecitabine, and patients can just go on taking for even months without any problem. On the other hand, if you have a young patient with a cecal mass, large mass, which is BRAF mutated, there I may want to use a triplet with bevacizumab. So based on that, you have different combinations. Now, in patients who have clearly unresectable disease, it is not shown that using all drugs upfront would improve survival as compared to using them sequentially. So what I'm trying to say is, you can use sequential therapies without any loss in overall survival if your goal is not to produce great response or do heroic surgeries. Now, in terms of first-line therapy, does bevacizumab add to outcomes? Now, the meta-analysis have shown that your overall survival improves by adding bevacizumab. This is both for right and left colon, right? The hazard ratio is 0.86. So I would say this is a useful drug, but you don't have to always use it in first line. You can always use it in later lines, especially if your patients have cost constraint. Now we have data with cetuximab, panitumumab, EGFR inhibitors. Here again, these class of drugs improve the overall survival over chemotherapy. Your hazard ratio of 0.85, and both of them are similar in terms of efficacy, cetuximab and panitumumab. But what we have learned after actually when these drugs were licensed was that these drugs work best if you do not have any mutation in the RAS-RAF pathway. So before you select anti-EGFR antibodies, you have to have the tumor tested for pan-RAS mutation. When I say pan-RAS, that means you need to test for KRAS exon 234 and NRAS exon 234. Also, in addition, we have also learned that about 10 to 15% of these patients may have a BRAF mutation, and BRAF is a downstream signaling protein in the same pathway, and patients who have these BRAF mutations also possibly do not benefit from addition of EGFR inhibitor. So currently, before you decide on what therapy to use for your patients, you would ask your pathologist to do a minimum. What we do here is we have a PCR panel, which would include pan-RAS, which is KRAS and NRAS. It will also include MSI, and it will also include BRAF. So once in about 4 or 5 days, the pathology will give you a report, and based on that, you decide. These are both predictive as well as prognostic. By predictive, I mean if you're MSI high, you do well. If you're BRAF mutated, you do poorly. Prognostic is again that you can use the anti-EGFR therapy if you do not have these mutations, right? Now, even in BRAF, what's interesting is about 1/3 of these BRAF mutation patients are also MSI high. And as I will show you that those MSI high patients can respond to immunotherapy. And also we have some drugs which are actually looking at inhibiting this BRAF mutations in this disease. Now, just about 5 years ago, there was an oncologist called Professor Alan Vinuk. What he did was, from his database, he just re-entered all the data of all the patients who had actually undergone a study which was comparing bevacizumab versus cetuximab in metastatic colon cancer. And he just went back and he re-looked and he just entered, okay, right side colon, left side colon. And once he did that, he was able to show that if you had a tumor on the left side, those patients particularly derived benefit from anti-EGFR therapy. And if you had a tumor which was on the right side, those patients did not derive any major benefit from EGFR therapy. So all of this has changed in the last 5 years, and now we look at sidedness in a very carefully. And the basis of this is what I discussed in the initial slides, that these are molecularly different tumors. Now, also the next question we have in the clinic is, these patients, when they get started on therapy, they all have advanced disease, incurable disease. After 4 months, 5 months, they'll ask, doctor, for how long can I stop? Right? So for patients who stop versus the patients who continue maintenance, is there a difference in survival? Right? So both these strategies have been tested, and these meta-analysis in front of you is showing you that this actually doesn't make a difference if you can stop your treatment now and you give them a drug holiday and you re-challenge with the same drugs at progression. And so that is a good strategy. So here again, patient factors come into play. I mean, at the end of induction, by induction I mean whatever 3-4 months therapy you have done, if you are left with a lot of disease, then I'm a bit I hesitate a bit in stopping all therapy. So maybe we continue 5-FU alone with or without bevacizumab as maintenance. On the other hand, if the patient has only a few nodules in the lung and a few lymph nodes here and there, I give them a break for 3 to 4 months, and then you can actually treat them without compromising on survival. Now, once you have decided on your first line therapy, I mean, what I just discussed, what do you do when they progress? So when they progress, it's simple. I mean, you basically would want to reuse the drug if it was quite some time ago. The only challenge with oxaliplatin is it causes neuropathy, and it's very difficult to reuse oxaliplatin if somebody has a neuropathy. But irinotecan can clearly be used. And also, what happens is, as tumors progress, they undergo different mutations, different selection. And this is where, again, molecular pathologist comes into picture, and we want to do a rebiopsy, or we want to send him circulating tumor DNA to look at newer mutations. And by newer mutations, I would mainly mean mutations in the HER2 target, in the HER2 pathway. Basically, HER2 mutations or overexpressions. BRAF mutations we already know. Some of the RAS mutations some of the RAS wild type can become RAS mutated. And also rarely you can have NTRK fusion. NTRK is neurotrophin tyrosine receptor kinase. It's a fusion for which we have a target available called larotrectinib or entrectinib. Now, is it worthwhile doing all these things? Do we have data? So, I mean, this is still early days. These are all expensive therapies and just 1 or 2 trials, but I just show you one trial. This was a randomized phase 3 trial, which has looked at, these are all patients who are progressing on 2 lines of therapy. And when you don't have much options left. So the control arm here would get your FOLFIRI cetuximab or irinotecan cetuximab. And then the treatment arm here was given a chemotherapy-free regimen. When I say chemotherapy-free regimen, if you see, arm A was given 2 drugs. One is called binimetinib and encorafenib. And there was another arm which was just 1 drug, encorafenib and cetuximab. These are all BRAF and MEK inhibitors. And what the authors were able to show, that this chemotherapy treatment-free arm, this was just a targeted therapy combo, improved overall survival. Now, this is not the best trial. I mean, this trial had some design issues. We'll not go into that today. But just to tell you that even for like bowel cancers, where traditionally unlike in lung cancer or other cancers where we have so much advances in molecular oncology, we are kind of making inroads in bowel cancers, and this is still early days. Now, I told you some patients may have MSI high tumor. Now, these MSI high tumors have what we call microsatellite repair and deficiencies. And when you have this, you have a lot of mutations going on in your cell. And once you have a lot of mutations going on, you have a lot of abnormal proteins expressed on the cell surface, on this tumor surface. And these abnormal proteins can actually be recognized and targeted better by your activated immune cells, as opposed to tumors which are MSI low. So based on this, and based on increasing efficacy based on data to show that immuno-oncology drugs like immunotherapy, like PD-1, PD-L1 inhibitors were shown to have some efficacy in later lines. So now these agents are moving forward. This is a first-line trial. Keynote 177. These are all patients who have MSI high colorectal cancer, and then you randomize them, and one group gets chemotherapy, one group only gets pembrolizumab, and you see the progression-free survival here. I mean, at the first scan you do, maybe about 40% would not respond, but then if you respond, you just look at the curve, it just goes flat. So if you respond, the chances that the response will be deep and durable is pretty high in this disease. And as compared to chemotherapy, where the response lasts for a short time, and then most patients will develop resistance and progress, these patients seems to have a better median progression-free survival of almost 16.5 months. This is again a chemotherapy-free treatment, and if it's available, if it's possible, this will be extremely good treatment for these patients. We have similar data with other class of drugs. This was Pembro. The next one is Nivo and EP. Here again, these are waterfall plots showing you how these tumors are responding, and you see that almost more than half of these patients would respond, and the responders do have a sustained response. So this is just a table summarizing in later lines. We have some options. Most of them are currently under investigations, depending on what you find on the molecular study of your patient, right? And just a few words on treatment of oligometastatic disease. Again, I told you that here in our multidisciplinary meeting, even if patients has metastatic disease, our goal is always to see if is it possible by the team to ablate all the metastatic sites, and therefore this concept of oligometastatic. By oligometastatic, you mean not more than 2 or 3 sites, and each of these sites are amenable to local ablation, right? So for these patients, what we do is we give them therapy, induction therapy. Most commonly, it's a tumor in the liver. After 2 months, you reassess, plan your surgery, and after 4 months, where you get maximum response, you do the surgery. And it has been shown that about 50 to 70% of these patients do survive for about 5 years. Now, many of them will recur, right? It's not that you're going to cure majority of these just because you're doing a heroic liver surgery doesn't mean you're going to cure it. The cure rates are possibly low at 20%, but by doing this, you're delaying subsequent relapse and improving their survival. Now, in the liver, when do you decide something is resectable or not resectable? So basically, the surgeon would mainly look at what is the remnant of liver left behind after his surgery. If it's more than 30%, that is the minimum you require for the patient to be well. And the patient should not have any extrahepatic disease. Sometimes it may not be possible to do an R0 because it's involving the portal vein or something like that. So sometimes you may have to resect 1 or 2 lesions and just do RFA for the remaining lesions. But as long as you kind of ablate all the disease, that's the goal. And that was in the liver. Now, what about in the peritoneal cavity? So you see some of these colon cancers, actually sometimes colon, also sometimes appendiceal cancer, they present with what we call pseudomyxoma peritonei, like the mucinous ascites in the peritoneal cavity. Even though technically they may have a large omental caking or disease outside, however, they have disease confined to the peritoneal cavity, right? And in these patients, doing a good cytoreductive surgery by an experienced surgeon does result in a good survival. Now, I'm showing you this curve. This is actually one of the randomized trials of HIPEC versus no HIPEC by using this drug called oxaliplatin. The curves are right on top of each other. So basically, the conclusion of this study was that using oxaliplatin did not make a difference. But I don't want you to see that. What I want you to see is the median survival in months. So these are all patients who have peritoneal metastatic disease who are undergoing systemic therapy followed by a good cytoreduction, and your median overall survival is 41 months, which is pretty good for a stage 4 cancer. So this is again something which is coming up, and we also are kind of we have people now who are trained, and we do offer cytoreduction plus minus HIPEC to a lot of our patients. So with that, I will wind up. It's 4 o'clock, and so conclusion remarks would be, I mean, it's been established that as medical therapy is safe and it saves lives, It improves the chances of complete resection for your patients who otherwise would be deemed palliative or inoperable. It clearly increases survival. And also with currently with improving technology, we may be able to better differentiate in which patients will benefit more as opposed to which patients do not require these toxic therapies. Now, the main emphasis should be a multidisciplinary approach so that the patient is benefited from expertise from various members in the group. And as time goes by, we'll understand better about disease biology. And once you understand biology, you know that biology always trumps anatomy, right? So so we have seen that, I mean, if you have a poor biology, then it doesn't matter what you do, and they all recur after some time. And moving forward with all these newer drugs which are coming in, slowly they'll be moving in earlier lines, and hopefully that will take the field forward and will improve outcomes for our patients. With that, I'll stop here.
Thank you, sir. That was a very simplified, detailed lecture on the colon malignancy. So just wanted to know, any questions? Anyone? Please feel free to put it in the chat box. Otherwise, you can even later mail to sir.
Sir, I have a question, sir. Prithviraj here.
Yeah, Prithvi.
Sir, how do we predict at what point the drug which we have used earlier has become susceptible again, in the sense that we know that we've given an adequate treatment-free period or a drug holiday?
Yeah. So generally it's about, you look at the time intervals, right? So we all know this concept of platinum sensitivity, right? So if your patient has responded well, and then the response has lasted 3 months, 6 months, right? The longer it is, the more likelihood that he'll respond again. On the other hand, if somebody has progressed within 2 months of you stopping the drug and then you re-challenge with the same drug, the probability is lesser. Okay, so one is the treatment-free interval or the progression-free interval. Other thing is the toxicity, right? I mean, so somebody like I said, oxaliplatin, even though the patient may be platinum sensitive, but you may not be able to use it because of neuropathy.
Okay, sir.
So I also want to know, I think we should be, I mean, like check again for a mutation. I mean,
yes. So serial monitoring whether tumor mutations change. Yes, they do. So like I told you, sometimes it happens under the influence of a therapy. Like for example, if you use cetuximab and you're blocking the EGFR, the tumor cells will develop resistant alternative pathways to regrow, right? So if somebody has done well, maybe for about a year on cetuximab, and then tumor is regrowing, this tumor might have developed a KRAS mutation, or this tumor might have developed an NTRK fusion.
sure, sir.
So if you have access, you must check again at progression. And most of the time, doing a biopsy may be challenging. So here again, the circulating tumor DNA may be useful.
Thank you, sir. So how different is a lymphovascular space invasion and an arso resection? Does it correlate?
So lymphovascular space invasion is a poor prognostic factor. I mean, so usually it is the pathologist would be reporting it. Sometimes for the rectal cancer, if you do MRI, you will be able to see that. Like you'll be able to see tumor infiltrating the vein. So the significance of this is that it is a poor prognostic feature. I mean, almost about 40% of these people will fail after surgery, right? And if you have this, you would definitely want to do the best for the patient, which means giving them adjuvant chemotherapy or whatever else you can do. Your second part was what? What was the other thing you asked about?
R0 versus LVSI, does it correlate?
No, R0 is basically the extent of resection. Yeah. So you can have an R0 resection, but LVSI in the tumor. So LVSI is a pathological finding. R0 is the completeness of surgery. They are two different things.
Yeah, so that means that LVSI will more suggest of a recurrence in terms of.
No, LVSI would tell you this tumor may have a high risk of recurrence, but if the surgery is R0, the recurrence may not be local.
Yeah.
Like for example, a rectal cancer which has LVSI, and the surgeon has done an R0 resection, the recurrence is most likely to be in the liver or in the lung elsewhere, not locally.
how often do we, so for a progression-free survival patient who had like ended up being almost cured, the follow-up in terms of repeat colonoscopy and other things?
So follow-up again, see the risk of relapse is highest in the first 3 years, right? So and then should we follow up aggressively? I mean, what are we going to do? So as I told you that if you pick up a liver limited disease or a peritoneal limited disease, you can still offer them a good salvage. So therefore, for the first 3 months, we'll do a CT scan every 6 months. Sorry, for the first 3 years, we do a CT scan every 6 months. And colonoscopy, again, colonoscopy is mainly it's for the local recurrence. And so that the risk of that is pretty low. So that is done every once in a year, not so frequently. As you'd be looking at systemic relapse, so you'll be doing CT scans.
Thank you, sir. Any further questions?
So can I ask one question, sir? So in
Yes,
metastatic disease, is it possible that certain areas of the tumor undergo certain mutations distinct to that which the primary tumor had? Some of those activating mutations or escape pathways may be activated in only the metastatic part of the disease.
It happens all the time. I mean, that's what you call tumor heterogeneity, right? I mean, different parts of the same tumor may not be alike. And that's the reason why our therapies fail, right? I mean, our therapies work only at a fraction of our tumor. And then the areas which are resistant would regrow.
So then that means what mutations we're picking up depends on where we have taken the biopsy from. It may be a different mutation in another part of the body entirely.
Possible.
Okay,
possible. That's why some people are the proponents of ctDNA testing. They say this is better, but then even ctDNA has its own challenges.
Okay, sir.
Sure. Any further questions? Like for those who missed, the lecture will be soon uploaded in our YouTube website. Thank you, sir, again, and sir is a very approachable teacher to all of us, and I think sir won't mind anyone having questions to be asked in person also. So thank you again, sir.
Thank you. Bye-bye.
Bye, sir.